Rich, how are you doing?
Doing great, Mark. How you doing?
Good, good. Excited to get into another episode of Airway Nexus. What are we going to talk about today?
Well, I thought that we should probably delve a little bit into obstructive sleep apnea, where it fits in the spectrum of our interventions, and also talk a little bit about the incidence of sleep apnea. A lot of people believe it occurs only in older males that have big necks, and we know that to be completely untrue.
Mhm.
And then also, where does upper airway resistance syndrome fit into this so we can better educate those listening as to how that might be part of their future airway dental program? And I wanted to just start off with just maybe hit you with a couple of facts. And, I read a paper that was published in Sleep that was published in 2025, May. And this
What
is
was the
the
title?
this is Unmasking Obstructive Sleep Apnea Estimated Prevalence and Impact in the United States. Wow, pretty cool. A nice paper, basically looking at the incidence of this. And they do report the problem of standardization of what is even considered OSA. Some are looking for a certain number of AHIs per hour, and it's all over the map. So they do admit that it needs to be some more maybe not standardization in terms of diagnostically, but when does it get reported? Unless it hits a certain number, people will say, well, since it's not severe enough, we won't even report this type of thing. Is that which I thought was interesting. But the bottom line in this paper is that over 80 million Americans minimum are living with OSA in the United States in 2024. 80 million. And the thing that's really remarkable is the significant number of those patients who don't even know they have the condition. And one could also say the same thing, if not more, for UARS. We probably know that number is higher. For example, if you look a little bit more into the data, as high as 84% of people aged 65 or above, depending on the definition in the population, have at least mild sleep apnea. I remember 10 years ago I learned 65 65. 65% of 65-year-olds have some form of obstructive sleep apnea. And you, in fact, have enlightened me that that number is underestimated. It's probably quite a bit higher. So I thought first thing we ought to do is let's just talk a little bit about these numbers and how this all fits into what it is that we do. And then I think we can then get into upper airway resistance syndrome.
Yeah, I think that's really, really good question because there's a lot of confusion there. And I think you really have to understand the history of sleep medicine because it's interesting. I believe that sleep physicians in general, but let's just focus on sleep physicians and pulmonologists that are boarded in sleep medicine. I think they largely are in a similar intellectual situation as dentists as far as their orthodoxy, not really understanding this question, and hopefully it'll become clear as we talk through this. I guess my first question is, I had not read that study in particular. Tell me, what was the sample size?
The sample size of that paper, uh, okay. Basically, they conducted literature-based analysis to identify studies of OSA prevalence in general community and adult population. I'm trying to look at the sample size because I don't remember.
Was it insurance claims database? Was it
Yeah, it was.
cohort?
I don't have that data, but
Okay, well,
I
something to think
will I
about.
will find it. You caught me off guard a little bit because I
Yeah,
wasn't.
yeah, no problem. But here's one of the things that in the mini residency we really teach. I think that if we were going to distill everything down, it would be understanding how to think, right? Critical thinking, how to think about the problem and be, you know, less focused on, I think being more focused on the question, good questions and then asking, how do we answer that question? Do we rely on what the authors say? And do we have a context within which the author concluded what they did? Or are we going to buy it hook, line, and sinker? And it may be factual, but maybe it lacks the context, what we call there are threats to the external validity. I mean, does that really apply to my population that I'm treating? So, as I'm very data driven, that's the other um, concept that we talk about. We got to really be data driven. And I tell that to my patients. Patients need to know, when they come in, all this data that we're gathering on them, unbiased data, we're putting together 3 to 5 sets of data, and then we're going to let it tell us the story in understanding the data, right? So otherwise, it's very easy to just jump and say, oh, there's no airway problem here, or we do just one night of oximetry or 2 nights, or we just look at a narrow palate or wide palate, whatever the case may be. We tend to just jump in and say, oh, likely this is what they have. Let's go ahead and treat it. Let's go ahead and play some Marpy.
Mm.
Well, I don't think that most weekend courses even talk about the medical indications. It's just looking at the phenotype. And I think that's a mistake. And this is why medicine won't take us seriously if we continue to be mechanical about it. So if the reigning statistics on incidence in sleep apnea in the United States had been 24% for males and 9% for females. And in 2015, the Hypnolos study, which was performed in Lausanne, Switzerland, looking at 3,130 thereabouts sleep studies, looking at a little bit over 2,000 individuals. It was published in the Lancet. Actually showed that the incidence of obstructive sleep apnea in Lausanne, Switzerland was 3 times that for females. It was a 27% for females, where in the United States it was purported to be 9%.
Mm.
And for males, it was 49%. It's almost twice what was reported in the United States. So think about that.
Yeah.
And it was a much better, I think, study that they were really getting into the numbers. And the other last thing is, in that population, I always ask the question, what population that you're looking at do you think is healthier? So it's going to give context to those statistics. The population in the United States or the population in Lausanne, Switzerland? I mean, intuitively, we know that there's a problem with obesity in the United States. It's pandemic. Well, the body mass index, which was one of the data points in the
Right.
study, was just under what would be considered normal of the population they looked at in Lausanne, Switzerland. Where do you think it'd be in the United States?
Much
I
higher.
mean, just intuitively, it'd be
Right.
much higher.
Yeah.
So basically, they're stating in a nice study, albeit maybe a smaller cohort, but still there's enough statistical power there with 3,000 PSGs, 2,000 plus individuals, that the incidence was twice that in males of what is important in the United States and 3 times that in females and in a healthier population. So this study that you just finished talking about, it doesn't surprise me at all. And of course, I know that
Right.
because I've been looking at this population, treating this population for a long time. Moreover, I could tell you that I understand what the problems are, is how do you define the condition? Like you say, mild sleep apnea. If you really understand the pathophysiology of sleep apnea, there's no the adjective mild is no better a descriptor of the condition than to say you've got mild cancer.
Right. And I wanted to also highlight the fact that we are so focused on, oh, it's the old guys that have this problem. But you and I know very well, when we're performing our high resolution pulse oximetry, we're finding frank OSA issues in kids. And even these papers are starting to highlight this data. For example, in the same paper in sleep, the young adults between 18 and 30 a population that we all treat all the time and kind of assume that there's no medications, they're fine, everything's okay. They're showing really high numbers of a percentage of those, even in this paper,
Yes.
that, we're 16% of those patients have got undiagnosed OSA, and it might even be higher. That's pretty striking. And then they do a little bit of a future projection too. They say, where are we going to be as a nation by the year 2025, or sorry, 2050? So let's go fast forward 25 years, and they're focusing on this group between 30 and 69. So this is sort of, in your prime, right? You're between 30 and 70. You're supposed to be. This is when you're living your life. You've finished with all your schooling. And they're saying that approximately half in that age group right there, that cohort, half of them will have, both sexes will have undiagnosed, untreated, at least mild OSA. So I mean, it's a huge problem.
Yeah, and again, it's not surprising. And now finally, people are really starting to look at the data. Dentists hadn't really looked at it before, and so they were pretty much hamstrung by the orthodoxy that the physician would impose on them, because this is our area and this is what it is. This is what we're going to focus on. Whereas I argue that this is well in the wheelhouse of dentistry, much more so than sleep medicine. And again, going back, yes, you have kids that have it at a much higher incidence. It just hadn't really been recognized. And as Kristen Guilleminault would say, babies are rarely born fat. So BMI and obesity has much less to do with it as does craniofacial growth and development, because that's really what the problem is from the very, very beginning. Moreover, it's a breathing problem first that becomes a sleep problem because during sleep, you're much more vulnerable. So instead of, like I say, the tagline, it's not just about sleep, we tend to focus about sleep.
Right.
It's really about breathing. And people don't get that flow limitation. So even if you look at the gold standard intervention that sleep medicine has largely dictated, um, it's a very primitive mechanical approach that only addresses the nocturnal epic of a 24-hour cycle. How about the rest of the time? And people really aren't aware. Well, they're breathing, but they're not aware. They may be aware of symptoms that tend to be isolated. They haven't connected the dots, but a lot of those symptoms, anxiety, depression, irritable bowel syndrome, adrenal fatigue and all that are directly related to this very basic function of gas exchange, but they're attributing it to something else. And then they fall asleep and then they start snoring and have apneas, hypopneas, or even non-hypoxic sleep fragmentation. So the problem is huge, right? And we can talk about why is it really getting worse, or is it that we're just now starting to see it? And you and Barry, I think 2 episodes ago, talked about that movie Wall-E,
Yep.
which is kind of visionary when you go back and understand this is where the human race ended up going, and then coming back where we were less mobile, and we were getting fatter and fatter, and what it meant. Okay, so um,
Before you go on, I
yes,
want to jump in, and I wanted to just clarify for dentists that are listening, and they're wanting to know at least how to talk to their patients a little bit, because because you listed quite a extensive list of systemic issues that are directly related to sleep apnea. I mean, this is not this is proven, documented so beautifully. We know it 100%. When a patient presents to us and they say, "Oh yeah, I'm on CPAP," and then you ask them, "Why are you on CPAP?" and they'll say, "Yeah, because I stop breathing when I'm sleeping, so my doc said I needed it." And you go, "Yeah, do you know what you're trying to prevent from that?" And he goes, "Well, I mean, it's really bothers my sleeping partner. My wife hates it when I snore. At least it helps out with that. And what else? Yeah, I wake up feeling a little bit better. So I'm sticking with it." And I go, "What other reasons might you be wanting to treat obstructive sleep apnea?" I just told you. That's it. And somehow I don't know where the breakdown's happening, but patients are not being told the seriousness of sleep apnea. They're not being told what it's doing to them. So could you please list for us again exactly what is it that you would feel comfortable telling a patient that they might have to deal with as a result of untreated sleep apnea? What kinds of systemic issues? You mentioned, cognitive issues, and you went through the list pretty quickly. Could you just highlight that for us again?
Yeah. So first of all, you have to think about what is sleep apnea.
Right.
Um, you just kind of cavalierly, which is what people will say,
Mm-hmm.
you stopped your breathing. So think about this. Why would you stop your breathing? Like when you're tooling around during the day, would you think that you were even remotely going to stop your breathing unless you were in a death spiral
Never.
spontaneously? And
Of
at
course.
night you do.
Correct.
The reason is because there's so much central nervous system damage and peripheral nervous damage from the snoring and the reflux that the relay to the brainstem that tells you to take the next breath, it's been broken from the trauma. So now you stop your breathing until you have an arousal. And so the brain's constantly kind of saying, wake up, wake up, wake up. And this is the reason why also alcohol or anxiolytics or any kind of medication that blunts your arousal response can be fatal. Because the one thing that's keeping you alive and breathing is that arousal response, albeit not working very well, but at least it wakes you up and then you're living another day, just barely perhaps missing a major medical episode like a heart attack or stroke, you were unaware of it, then you start understanding that it's an end stage diagnosis. Whereas upper airway resistance syndrome,
True.
which has a very viable autonomic nervous system, it's not going to allow you to stop your breathing. So what it does is it fragments your sleep. It's constantly arousing you, constantly arousing you. You have wake up all the time. The UARS patient says, yeah, it takes me a long time to fall asleep. And then once I fall asleep, I wake up multiple times and then I can go back to sleep. That's a sign of health. That means the autonomic nervous system hasn't been damaged so much. And so you're constantly awaking. So the autonomic nervous system is doing its number one job, which is keeping you alive and keeping the injury to the brain and other organ systems from happening. But it comes at the expense of your sleep. So you wake up fatigued. And you wake up fatigued, and what's going to get you through the day is your adrenal function. And then that becomes your norm. And that adrenal function manifests as fatigue, anxiety, depression, irritable bowel syndrome, heart rate, all those things that we get into the mini residency that gets underreported. And in fact, you tend to also be hypotensive and low body mass index because the autonomic nervous system, because it's so healthy, it's hyper responding to the heart spikes because it can, and it's dealing with that sympathetic drive with a very viable vagal response or the parasympathetic response. So that manifests as low blood pressure. It's a compensation until it doesn't work. And then you transition eventually to the OSA from night after night after night out of the vibratory damage to the nerves and the mechanoreceptors that are keeping you from stopping your breathing at night. So that gets defined as healthy in that you aren't having these bad episodes of apneas and hypopneas. And so the system's pretty much set up to identify just that population. And what is the answer? What's the gold standard? It's CPAP. And so the study that came out about 2 years ago, maybe 18 months ago, had a little bit of bad news regarding that. And coming out of pulmonology, that as it turns out, the CPAP, as it pneumatically stints the airway, the stretch receptors actually release angiopoietin, which is a mediator that is super inflammatory, and it downregulates what's called VEG4, which is a cardioprotective peptide. So bad news, long-term use, and they've been arguing this for a long time, looking at why cardiovascular morbidity hasn't really changed the way you would expect based on the storyline that if you deal with your sleep apnea, where you're having heart attacks and strokes, if you follow through with the antidote, the solution, CPAP, that it would obviously decrease it. And so some years ago, there was the 20-year retrospective of the Wisconsin study that defined sleep apnea events greater than 5 as being a problem, looked at it and said, you know what, cardiovascular, and it was published in the New England Journal of Medicine, cardiovascular events have not really changed that much. And so there's this editorializing going back and forth within medicine saying, well, what's up, man? And the argument was, well, of course, doesn't it make sense? Compliance is really low. They don't do it. So at most, the average person that's using it, usually males, are using it for the first half of the night and only at 30%. And yet we know it's the second half of the night, which is the most dangerous half of the night because you have more REM cycles. That's when you're going to have more collapse. And so, yeah, it stands to reason that if you're not using it or you're using it at very low levels, that it's not going to change. Well, this other information from this study came out showing molecular explanations for it, the inflammatory response, that CPAP actually increases cardiovascular risk in hammering the endothelial system by upregulating hemopoietin, downregulating VEG4 without getting into the weeds of the things that we get into in the mini residency, that it's not a good solution. And let's add one more layer to that, Richard. And that is that when we're talking about this, what do you do with that 20 or 30-year-old, 40-year-old that is diagnosed now and they have to be committed for the rest of their life because all it's doing is managing, it's not curing. And we know that there's side effects long term. So the solution that's offered is not very good. And
Right.
it's going to increase chronic disease. This is our concern. It's going to increase chronic disease. And that's why we say we've got to have early intervention. We've got to recognize it very early on. And then we have to deal with the why, structure, function, and behavior. We have to deal with the flow limitation due to structural deficiencies, craniofacial growth and development, the functional compensations, myofunctional issues, open mouth breathing, tongue dropping back. Those are myofunctional solutions, of which medicine has provided some solution, like a hypoglossal nerve stimulator at night, right? The Inspire, right? It's a Bluetooth hypoglossal stimulator that they'll keep the tongue from dropping back while you're sleeping. And we know through the European studies before that eventually becomes less and less effective. So there's really no good solution for obstructive sleep apnea, especially as we start diagnosing it earlier on in a population that people are realizing it's higher and higher incidence, and why we as dental providers are in this perfect situation to provide the solution by early interventions and non-widget driven treatment. So just placing in MARPs and oral appliances is not the solution. It's really understanding pathophysiology and the whole problem. So that kind of brings us back to your question that we started the episode with, which is, what's going on here? Where did it start? So Kristen Guilleminault in the 70s, in the 1970s, before the specialty of sleep medicine had been defined. And so this is some of the very early work that helped him with Remmers and a couple others to establish the specialty of sleep medicine. He, before that, started looking at not the fat Pickwickian male, which is who Remmers was looking at, that defined what's called hypoventilation syndrome, which was the Pickwickian male, 30-inch neck, big fat belly, couldn't move the diaphragm, those people were so sick. That's late stage metastatic cancer. They stop breathing. It lasts for 10 seconds. It's called that an apnea. There's a drop in oxygen. That's how they started. Guilleminault in the 70s was looking at children. And what he did is he used an esophageal probe. So he's putting this little probe through the nose, and the probe was in the nasopharynx, right behind the tongue. And the very elegant, sophisticated approach to really understanding flow limitation told him that these children were having these constant drops in airflow that could only be measured very sensitively in a healthy individual with this esophageal probe. And that's how he started defining this problem. By the time it gets to a snore, the snore is definitely a really bad flow limitation. And he started looking in these sleep studies, the sine wave of the flow, if you will, that it was like this flattened out chair. This in one of the leads, the respiratory lead in a typical sleep study, that it was flattening out at a very high rate that was leading to all these problems. So he was looking at this with kids. What ended up happening is over time, the community, the specialty of sleep medicine was established. They were mostly focusing on fat males, but he already knew about flow limitation. So they were establishing on a sleep study, what do you look at? The EEG. They have a chest belt, respiratory belt. They have the flow. They substituted what was the most accurate and sensitive way of measuring the problem with a nasal cannula that also was able to measure that flow limitation indirectly, but not as well. And there were a lot of arguments in the literature at the time. Oh, it's great. It's easier. It's less invasive. It's more practical. And then in many sleep studies, they even stopped doing that. So then it got to now a home sleep test that is starting to, so you're basically dumbing down a study to artificially change the incidence of sleep apnea because of the way it was being measured. It was always there.
Lowering it,
If
lowering
they
the
were lowering,
incidence.
they were moving. And a lot of that came from the payer. Medicare started saying, we're going to start scoring it. We're not going to accept any sleep study that does uses a 3% oxygen desaturation in an apnea event versus 4%, because that's one of the criteria that's called 1B scoring that you know about.
Right.
So I guess in summary, what happened is the incidence has increased because we're getting more sophisticated and really understanding the problem. And number two, the jig is up in how we're measuring it. We're understanding that there are lots of problems in how we're measuring it. And so now, and then the solution now is forcing this discussion about uh, that it's not really a good solution.
Right.
And then this study that you and I reviewed 2 episodes ago
Hmm.
on that big interdisciplinary group from the East Coast that was looking at airway size measured by MRI
Right.
and brain development, crystallized and fluid intelligence, emotional intelligence was a marker for brain development in the adolescent. So now we start understanding how the brain is being damaged. It's being hit early and often, which Kristen Gaiman already knew. Now it's calling to attention what the stakes are.
Right.
So when we start looking back at that 40,000-foot view and start looking downstream at the incidence of chronic disease that's gotten us sicker and sicker and sicker, and you now hone in on the problem, what I call the elephant in the room, which is gas exchange. It's not about what's in our diet per se. It's not um, red colored dye number 9. Yeah, those are problems, but that's where everyone's, looking. That's the shiny object everyone's looking at. They're missing this whole thing about flow limitation, which is largely determined by the facial skeleton. What we dental providers deal with every day. We just have to stop looking at the pearly white things we call teeth, right? That's just a part in that system. So I think, and then again, in a siloed disease management healthcare system, the physicians were really up in arms with the dental profession back in, the 80s and the 90s, fighting who's going to deal with this problem. It's really a sleep medicine problem. This is a specialty. You have to be a physician. You, as a dentist, can't really deal with it. So those rules in that fight was fought out, and in the end, dentistry won the fight, if you will, in that it was within our wheelhouse. And in 2016, the American Dental Association mandated that the dental provider really needs to start looking at this. We don't know how to look at it, but we need to start looking at it. Well, that's the mini residency is all about, is how do you look at it and how do you treat it very early on so you have a healthier population, not less decay, not less managing temporomandibular joint problems and dental crowding. Yes, we treat those, but we really treat a much higher problem having to do with the health of the population. It all comes down to the data, the measurement, understanding what you're doing, and really you learn from histories, which is what I just kind of reviewed the history of the problem. And now we're full circle to problem of why upper air resistance syndrome, it is believed, is much higher incidence than sleep apnea. So the incidence of stage 1 and stage 2 cancer is much higher than terminal cancer, almost by definition. You just don't know it in stage 1 and stage 2. So think of it that way, right? So do we want to deal with stage 1 carcinoma in situ in
Of
stage 1?
course.
Before, of course, right? So it all comes down to how we're measuring it. So you get the parallel that I'm saying. So obstructive sleep apnea end stage is the tip of the iceberg, what we see above the waterline. It's obvious. But if you don't look below the waterline and see how huge that iceberg is, out of sight, out of mind. You can only treat what you see.
Right. Yeah, I that was great. I want to kind of circle back to the my last question because it really is about, even though that part above that portion of the iceberg that is visible is clearly understood, but I don't believe it's understood well by patients. I really don't. I gave the example of the 58-year-old patient. He has all of the signs and symptoms of someone that's struggling with airway. And just a few questions into the interview with the patient, I found out that in fact he's been on a CPAP for 10 years.
Yes.
And I said, you know why you wear that CPAP? And he goes, well, yeah, because I stop breathing and I snore. And I said, yeah, but what do you know? Do you understand what it's really doing for you? And he looks at me kind of like, well, yeah, it's keeping me so I can breathe at night. And I go, do you understand the medical correlates? What can happen with? Let's just assume the CPAP is good for just a minute, Mark. I mean, we know that it's not. Obviously, it's a problem, but let's just assume it's a good intervention. It's in many respects, the best intervention medicine has. They don't have another one. They have us is really what they should be thinking. But but what can I tell? Because I get the impression that this guy he's casual about it, and some of them tell me, oh yeah, when I travel I don't take it, I don't worry about it. And some of them will when I'm on the road and I can't sleep well, I just I have these medications to help me sleep, or I just I'll drink an extra glass of wine. And in fact, that might in fact be the worst thing they could do. So
Yes.
could you just give us, what can I tell my patients are 3 or 4 things that can happen as a result of the sleep apnea effect to their overall health? What is it that we should be saying to patients about what could be impacting their health? I mean, you mentioned many things. I just want to make sure we're really clear on that.
Yeah, absolutely. Okay, so again, these are the things we talk about in the airway mini residency is how to do it in a way that is effective to communicate with the patient. Because in healthcare, our number one skill is learning how to communicate with another human being in a very specific way. It's not using some technology to find something out.
True. Yeah.
That's just our data gathering. It's really how do you communicate something to a patient that lands, that motivates them to understand what the real situation is. That's why you go to a doctor of any stripe, right?
Yeah,
If
fair
you say
enough.
cancer, the C world, everyone goes, ah, their hair is on fire. What do we do about it, right? So it's kind of the same way. How do you communicate the seriousness of it?
Right.
So I ask, first of all, depending on where you are in that journey of airway, the types of questions that you ask. So if you're looking at, let's say, a patient that you know, say UARS versus OSA, just to kind of parse it out a little bit, I ask that question of related to their symptoms, and I'll say, well, how many times do you wake up at night? I wake up all the time. What's that have to do with my teeth? And then I'll say, well, tell me a little bit about how you sleep. Well, what does that have to do? I sleep on my stomach. What's that have to do with, why I'm here? And so you start asking the questions, and then you say, well, do you have anxiety? Yeah, 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 but I'm taking a chill pill for it. And then I start talking to them about what the problem is. And I use different analogies. Can I just share one? One that tends to work is that we talk about. So I have these three caliber straws. One that's like the big fat one that's like the In-N-Out burger one, and the cocktail straw, and I hand them the big one, and I say, okay, just visualize you're floating on a pool, jacuzzi warm. You're breathing out of this, and your head's underwater, and you're breathing out of that. Would you say that what I'm saying is true? That maybe you're getting enough air. It's not like a big snorkel, but you're okay, right? Yeah, yeah, it's okay. Yeah, okay. Then I hand him the In-N-Out burger straw, the regular straw. I'll say, same scenario. Would you agree that probably the effort to breathe has increased um, consciously, or am I putting words in your mouth? No, no, no. It's harder for me to pull air through that smaller straw. They get it, right? Do I need to hand you a cocktail straw? And they kind of get it. I say, could you imagine that if you were breathing with that regular straw that we call the In-N-Out burger straw, you know what I mean? That if your head was underwater having to breathe out of that, could you imagine that you might be a little anxious and have anxiety? Yeah, yeah, of course. I'm already having a little bit of panic attack thinking about it. I go, do you understand the difference between physiologic stress and psychological stress? And that's the problem, is that the limbic system has an area in the brain that has language associated with it. So if you're anxious or have anxiety, your brain's always searching for the reason. It's like it's your boss, it's your workload, it's the to-do list, it's the traffic. So you are assigning that feeling that you have from the autonomic nervous system to some solution that you could deal with. I got to quit that job. I got to not drive during traffic, or I need to deal with that. Whereas the whole time is coming from the autonomic nervous system that has no area in the brain to consciously tell you that's what's going on. So that's part of the problem, is I want to parse out those two things. And the feeling is the feeling regardless of the reason. And there are patients on a lot of these medications that seemingly look healthy. They're on anxiolytics, they're on antidepressants, and et cetera, et cetera. And I tell them, I want you off of that. And the clenching and the grinding and the reflux and all those other things that you are having treated also that are pill-driven solutions, I want you to understand that as well. The temporomandibular joint problems, you want me to treat that with a splint, that you really aren't understanding the problem. So I kind of go through and let them understand. So that's a UARS patient. Very upregulated sympathetic drive that causes a lot of the symptoms. For the OSA patient, those patients must be treated by the sleep physician once we screen them. But once they come back after their sleep study, medical legally, we're in a good solution or a good position to be able to help them with the solution they really don't want, which is the CPAP or an oral appliance even, because those have problems. And so I could talk to them about that. And the way I talk to them about it is really understanding what we talk about in the airway mini residency, what's called bioregulatory systems medicine way of thinking versus evidence-based practice. So there in the United States and throughout the world, as of the 19 80s and mostly the 1990s, this whole concept that David Sackett brought to academia called evidence-based medicine or evidence-based thinking was a call to do away with the in my hands mentality. I know how to use a scalpel. So now they start saying, well, where's the evidence for that, right? And so that ended up hitting dentistry in the late 80s, and the ADA finally accepted the resolution, the mirror medicine, where now it's the randomized controlled trial that's telling you what to do. And bioregulatory systems medicine, which started in Europe and now is spreading, is saying, okay, that's one way of looking at the problem, but the body doesn't work that way, and our outcomes are not that great. The statistics are really, really clear. Let's look at this problem in three different levels: the molecular level, the cellular level, and the organ level. Well, we as providers in an evidence-based approach are really treating patients based on the organ level. We really don't see what's going on in the molecular or cellular level. Physicians do more with their labs and their lab and their blood studies and their panels, and they're saying, well, this is what we think is going on. Us dentists are more mechanical. We're looking at the teeth, the joints, the muscles. We're not really understanding the molecular level. Let me just say that the periodontist specialty is the closest to physicians in that they do look at inflammation. They're looking at the molecular level of what's going on with the patient. They're looking at the biome. They're looking at upregulation of rankle and osteoclastic activity and what causes loss of bone and implantitis and things like that
cytokines, and yeah.
and cytokines and all that.
Right.
Okay, so they're looking at it and they're treating at that level to some extent. The rest of the specialties, very mechanical. If you're a surgeon doing double jaw surgery, you're looking at CVCTs and planning surgery, the planning software that's still very structural oriented. Well, with this phenomenon of flow limitation, we really have to understand what's happening under the surface of the inflammatory marker. So I talk to my patients about that, say, do you know that your child that has a little snoring and loud breathing, you understand there's this cytokine storm, this inflammation that you can't see it, but it's very well documented. Their brain is full of inflammation, and it's causing changes in the brain, and it's predictive of type 2 diabetes and obesity, and it's affecting every organ system. And yes, it may not manifest for years. The next stage for your kid is going to be tonsil removal because now they've swollen up, and you continue to chase symptoms. Why don't we start really looking at what's going on? Because by the way, how's your kid doing in school? Oh, he's got a tutor, right? And he's diagnosed as having ADD, ADHD, and what are they taking Adderall and Ritalin? Is that really what you want for your kid? Well, that's what they tell me. You start understanding mostly that's sleep fragmentation. That'll go away if you get him to function properly. So it's a long-winded way of connecting to another human being in an elegant way for them to understand what the stakes are. For that male that's got sleep apnea, out of sight, out of mind, they don't care. The snoring's the problem. Now it's been managed. Leave me alone, right? But they don't know, and because most providers, even the sleep physician, doesn't tell them the reason is because your neurology and your brain is so damaged, and that memory loss and that forgetfulness, by the way, that your wife's always bothering you about, that's actually a marker of your chronic disease, and they can't be bothered, right? So I think we have to be better providers to really understand a very complicated milieu that is really the nexus of our health that's generating all this chronic disease, the risk for all this chronic disease. It's not the only thing, but it's a major marker that's being missed. And so I think there's no easy answer in a hour-long podcast to say how to talk to the patients. But if you can walk away with an understanding that there is a difference between obstructive sleep apnea and upper airway resistance syndrome within the spectrum,
Right.
and that maybe if you start understanding how to ask screening questions
Mhm.
that land with the patient, then those patients now are connecting the dots because of social media and people's airways everywhere now. And they're now thinking that it's a MARPE or it's, some kind of surgical intervention or some appliance to treat it, that they understand that you understand what you're doing, that you could provide maybe less invasive ways of the problem that have lifelong outcomes by dealing with it earlier and earlier with their kid instead of dealing with the dental crowding when they're preteen. When they understand that dental crowding is not the problem, it's all the upstream things that lead to something that you finally now recognize. This is where we as providers have to be trained to stop being these mechanics to see the pinhole leak in the pipe that now has caused a slab leak below the surface. We should have known that there was a problem way before that occurred. And by really delving really into the things that are under the surface. And most dental providers work very hard and they're dealing with the low-hanging fruit of the symptoms because that's the way we're trained. And our population is trained to accept that gold pill, solution. But they're fed up with it because now they've got a list of medications they have to take individual symptoms for. When they start realizing that it's connected, most of that stuff is connected, then that's what they want. And so where we have to be as instructors in this, teachers in this, we just have to be very effective in teaching the provider how to make it simple, how to look at a complicated thing by asking screening questions, giving data, say, hey, look, let's just go ahead. What's it going to hurt? Let's just get 3 or 4 nights of high resolution pulse oximetry. Let's see where it leads us. And then they come back 2 weeks later, and then you see that their heart rate during while they're resting is 60 beats per minute, but then while they're sleeping, it's at 80, with spikes up to 100. And then you start talking to them and go, do you think that makes sense? Tell me. And then you start explaining it to them, and they go, oh my gosh, that you start connecting the dots, and then say, Doc, what can we do about it? So I think that is our challenge, is to understand an area that's largely been out of our domain because of the way it's been measured and because it's more kind of internal medicine approach, um, that we really start really understanding that instead of just treating the accident after it's happened, let's really check the brakes. Let's make sure there's good tread on the tire. Let's make sure the engine's working properly and efficiently. Let's make sure that they understand what the ramifications are when there's sleet and snow at the speed of how you drive. Those are the things that we really need to do to lower risk. Not that we're going to prevent everything because we can't. All we could do is lower risk and benefit, right? And the patients, once they understand, mostly do the right thing, right? They take their supplements, maybe they exercise more, they start trying to feel better and getting off the medications. So this is a very long-winded explanation for a rather complex problem. Simple question that you ask, what do you tell your patient that comes in that blows it off? I find with the obstructive sleep apnea patient, I ask them, do you have a family? Yes. Are you married? Yes. You have to understand that even though you don't care about it and that you're fine, you have to understand that if something bad happens to you, what that means to your family, right? So do you have good life insurance? What do you do? Do you feel consciously, ethically that you have a responsibility to your family, that it's beyond snoring, that if you have a heart attack or stroke, who's going to take care of you? They start waking up and they really start understanding. It's just that we haven't been trained to talk to our patients that way. They come in, you're asking me about sleep. Doc, I'm here for my teeth. I'm here for that problem that you talked about, that blood that's coming from, pus that's coming from that tooth and that implant. And then we, like mechanics, we deal with that one problem and we graph and we do that. We have to kind of step back and be more the internist, if you will. And then when you start understanding the whole domain of that structure that you have to treat somewhere down the line, like I always say, We could deal with the chairs that are at the top deck of the Titanic and worry about how straight those chairs are only after we deal with the gash in the hull. Right now, we're just dealing at the top deck with very little appreciation of what's at the hull, and it only lands with you personally when it's you or your family or your friend that all of a sudden the light bulbs go on and go, you just described what's my situation because it's that common. And once you start dealing with it as a provider personally, how can you, in good conscience, with all your longtime patients that you know now have the problem because now you see the airway problem, how can you ignore it? And so I think that's what the mini residency does that can be somewhat stressful. The lights go on. Those aha moments are, wow, this is everywhere. And we never promised that there would be less stress in practice. It's just a different type of stress. All of a sudden you realize I have a lot of work ahead of me. I've got to deal with this problem way beyond placing implants and smile design. It's great and that's fun, but I'm going to do that after I deal with these other problems. And my patients are loving me now. And everything I say, they will do because now they know that they're feeling better. They're off of their medications. People are telling them that they're doing better. And then now you're the real physician of the mouth. Doc, you know that full mouth rehab you've been talking to me about? I get it now that you fixed me for the rest of my life. I'm experiencing life differently. Tell me, where do we start? And so it is not about the fiduciary event. Once you really understand, the patient understands what the problem is. People are always trying to, we're trying to stretch their healthcare dollars, but the healthcare dollar spending is going to be a function of them really appreciating what their situation is. If it's elective and they've got extra money, it's discretionary, no problem. This is what I want. I want a Ferrari instead of my Volkswagen. I want to go on a Tahiti cruise instead of, dealing with my utilities. People start paying for their healthcare differently when they really realize what it's going to mean to them personally. And everyone wants to be well. Everyone wants to be healthy. We just have done a poor job in communicating that. And I think we've got to really retool our practices to communicate with the patient differently with this very pandemic problem, which is what we started with. The incident of sleep disorders and breathing disorders is huge. It's probably 8 out of 10 patients that sit in your chair have this problem. And I think when you start learning how to communicate it, and you've gone through it, Richard, as a world-class academician, teacher, and provider, you went through this transition where it's like all of a sudden, oh, I get it. Now you're going through the stress of retooling your practice. I mean, you told me, I think this last week, that you upgraded your CBCT field to this field to take airway images. So you're solving the problems in your practice to be able to provide these services for your patients. And so I think that's where it starts. And so I guess we can wrap it up with that and
Okay,
maybe
that
end.
yeah, that sounds good. I mean, I think we've covered so many aspects of that initial study and what it means to us and where we're at as dentists. And one thing I'd like to just remind everyone is that we're still dentists, or we're still going to get to do
Yeah.
those wonder. And you mentioned it, of course. We're and I what I'm talking about is even before the deck chairs on the top deck of the Titanic, in terms of all of that beautiful work we can do in terms of veneers and occlusal rehabilitation, things like that. The airway treatment intervention approach is also very hands-on. There's a lot that we get to do that's kind of fun. I mean, it's new. I mean, it may be adjusting and bending wires and doing things, but there's a lot of surgical part of it. There's a part of it that is pseudo-surgical. There's parts of it that are kind of related to orthodontics and to a lot of behavioral management. There's a lot of, and this is all stuff that we do with regular dentistry too. So it's just a different pathway. And then in the end, honestly, in my practice, I'm gearing up to not do that dentistry at the end because I mean, after 40 years, I've kind of been there, done that. I mean, if I don't have to do another veneer or an implant or something, it's not going to be the end of the world for me personally.
Yeah.
I'm just more excited about this newer, let's just say more mindful, appropriate, health based approach, global approach, a wider, broader view of what's really going on. Um, and it's interesting how, Mark, you and I were both, we were going to be oral surgeons, we were going to be medical doctor, oral surgeon, DDSs. We were going to be super dentists, right? We would get up in the morning at the crack of dawn and scrub in and go into to the surgeries, and we had that motivation, and I think we had the resilience to go through a program like that. And here we are 40 years later, we're doing something that could arguably be considered even, I don't know, more important to me anyway. I don't know about others, but to me, this is the most important kind of dentistry I can do. Dentistry that is going to change lives in a measurable way, going to be able to get people to the right providers, whether it be me or another person or a combination or a team approach. It just seems like what I really wanted to get into in the beginning.
Yeah,
Think
no
think
question, Brandon.
beyond the tooth, thinking beyond the tooth, and I think it's clearly the pathway that a lot of people are gonna I think are gonna catch on to. I want to caution people against easy remedies. Let's be mindful of the fact there's a lot of stuff going on out there that looks attractive. And for example, I just went through some laser training. We purchased a erbium YAG laser for the purpose of removing veneers atraumatically, which I think is a really nice thing to be able to take a laser and remove a veneer without having to cut off the veneer and damage tooth structure. But during this presentation, the trainer, who is a dentist, was talking about how we can solve sleep problems by just removing part of the palate with the laser. And I was like, oh my God, that's the moment that I kind of put a timeout on the training. I think we're good. We're good. Because, wow, that was so completely wrong to be able to speak like that, that this is the approach that we should be taking. I mean, maybe it's part of an approach. I'm not going to criticize that all of these interventions, MARPs and some surgical interventions, maybe they're part of an approach, maybe they're not part of an approach. And I don't want to try to criticize the person for talking about their approach, but I think that it's better if we just step back a little bit and let's approach this with a little bit of intelligence. Let's have some patience. Let's take our time to truly deeply understand what it is that's going on and be willing to struggle a little bit with understanding it because it is a completely new approach, Mark. It's not dentistry as usual. Here's another thing to add. This is it's a reset.
Yeah.
It really is. And it's
And
not a bad reset. It's a
no, I
great reset. It's a beautiful reset. But it is a reset. Let's face it.
well, I'll say that there's no more exciting time to be a dentist than now.
I agree.
And to be less of a mechanic. And the example that you just gave, I think you and I are in good stead after 40 years of practice to say what I'm going to say of what you just described, that um, um, individual instructor that was giving that course, we've all been there. And I could summarize it no better than what Mark Twain said. It's not so much what we don't know that gets in the way or gets us in trouble as much as what we do know that ain't so. So he just didn't know, and we have to go into healthcare with a full dose of humility. And it's only when you've been practicing a long time that you really understand the depth of that. And I think that a real world example of what you just said that's very exciting, looking at the periodontist, what we still do with our hands to correct problems, but with a different context. is that we have an entire population that have teeth that have been pushed towards the buccal cortices that create dehiscences, fenestrations, and attachment loss that may be non-inflammatory that have been traditionally treated, let's say, with connective tissue grafts to stabilize that, and then you could do your restorative on top of that. That still needs to be treated, but I'll argue that that current orthodox thinking in the periodontal community is overtreating the wrong problem. That really the problem is not so much the dental alveolar loss of attachment as much as the deficient facial skeleton. So the solution that we get into is you really need to skeletally expand that facial skeleton and then move those teeth into the bone. Okay, so those are things that we as dentists will do, but in the context of understanding that the biggest benefit from all that is not stabilizing the attachment as much as in that process because of the medical indications that the patient is seeking to accept the treatment for, as well as treating the dental problems, is really making their life better because now they can breathe and sleep better because you've addressed a facial skeleton that has flow limitation, but now you could move the teeth in, and instead of doing four quadrants of connective tissue grafts, of which you only do one quadrant because the patient doesn't want to have the other four done after they have the post-operative experience, right?
Right.
And yes, you can use alloderm, but it's super technique sensitive. It'd have been better to go ahead and do corticotomies, move the teeth in the bone, and then now you've got four quadrants and the patient's healthier and more stable. And you've corrected these. So that's just one clinical example of how much dental work we have to do. And now you could place the implants in a much better place and a better angle. And now you've got a much nicer arc of smile. The smile design is not about arrangement, display, proportion. It's about just a beautiful white smile, a better phenotype that patient also happens to be healthier, they're clenching less, they have less TMD, they have all less problems. So we do want to have our cake and eat it. And all those things, I call that the icing on the cake. Kind of like I like to get the rows of chairs on the top deck of the Titanic nice and straight. I love that. But now I'm doing it after that's the icing, if you will. But
Right.
I feel better about it now
Of course.
that the reason why they all got messy is because the ship was going to one side because it was listing and taking on water and all the, all the chairs went to one side. Now I fixed the underlying problem. The boat is going to stay afloat for the rest of its life
Right.
avoiding other icebergs. And now I could go ahead and get those chairs nice and in even a better arrangement than before. So that's kind of a analogous way
I love
of,
it. I love the analogy.
does that make sense?
Yeah.
Yeah.
Yeah. It's awesome.
So anyway, I guess that really even takes up our time for our weekly learning moment. I think that is our learning moment, the
I
way
think
we ended
so.
up,
I would
right?
agree.
Yeah.
I would agree.
So
You
to
know,
be continued.
yeah, to be continued. And the the Airway Mini Residency 3.0 is it's live. You can register for it. It starts in January of 2026. Let me see here, the 16th through the 18th. So it's a Friday, Saturday, Sunday. That's our first course. Our second course is in the first week of May, and we will continue to have courses throughout the future in these first two courses, which is really kind of the onboarding pathway to get into the Airway Nexus. And the Airway Nexus is getting into the hands-on how-to courses. But doing those courses, those secondary courses, in the context and with a deeper understanding of why you're doing things and where it fits into the workflow is so much more valuable. I mean, if you want, you can go take an airway, you can go take a MARPE course, go for it. Go take a MARPE placement course someplace. But if you don't understand where to plug that into your overall treatment, and why and the nuances of that, the timing, I think it's a little bit like let's not sit down and learn how to hammer a nail into a 2x4. Let's understand how to design a house first. let's analyze the lot and see what makes sense on that piece of property before we spend time with hammers and nails. And I think that's basically our approach is let's get that basic foundation first, which, by the way, guys, is not easy. It takes a lot of intellectual work, some introspection, some willingness to change. Connecting dots is not that easy. Dots need to be connected with some effort.
But
But
here's the exciting thing, though. I mean,
yeah,
I think the 3.0, the iteration of the airway mini residency, which, I've been doing this for 15 years, and the one thing that I did not understand how to do so well that we are now doing it, I think, and I'm very excited about it in this iteration, is that the provider takes even that first 3-day course, will immediately on Monday be able to um, dramatically change their practice in a very positive way and in their community
absolutely.
that will result in a lot of referrals, and then they get better and better and better at it. What I did before, I think, was a lot of hours that was very didactic and okay, now I get it. How do I actually do it? How do I get paid as a provider? I think there's a reality to that. We have that
Yeah,
responsibility, our families and our staff. Well, this iteration actually, you'll walk away immediately at the end of that 3 days the following week to see things first that you never saw before, and all of a sudden realize, wow, it's everywhere. But now I could really start identifying it and actually get paid for it. And then the next thing is I really want to work on my tool chest of all those things that services I'll provide to fix the problem. So that's the beginning of your journey. So I think that's the difference in this iteration now is that it's a lot more practical than before. And I think e- everyone's gone through it before, they enjoyed it. It was like really like, wow, this is really, I should have learned this in dental school. Now I can't go back. Or if you go back, you now have less satisfaction in what you do because you're having to ignore what you see and understand, and you have to deal with your conscience in that way. It's kind of like you get out of dental school and you work for a corporate clinic. You get burnt out pretty quickly when you start understanding that sometimes you're not doing things that you feel so comfortable with. It's the Hippocratic oath that we took. Um, do no harm, but as importantly, that's called non-maleficence. And the other underpinning is called beneficence, meaning it actually has to benefit the patient. So we can't just not do no harm. We also have to benefit the patient. And the one thing about airway more than anything else is that beneficence. You will benefit the patient way beyond the pearly white teeth and the gums and the joints. And that's the exciting part of it in the mini residency. We look forward to that. So anyway, Rich, thanks for another exciting podcast that we covered a lot and maybe went down some rabbit holes as we oftentimes do because it is complicated, but hopefully the information is meaningful and look forward to our next session.
as do I, Mark. Thanks so much, bud.
All
Always
right,
good to
take
spend
care.
time with you.
Have a great day. Likewise, take care.